السلام عليكم ورحمة الله وبركاته. السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله.
عليكم السلام ورحمة الله وبركاته.
We can start إن شاء الله. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم آمين وأجمعين إن شاء الله. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل. We can start with our cases today, and the cases today are simple, relatively simple comparison to the previous cases. And we can start with the first case. Any volunteer for the first case? This is normal daily work in ultrasound. Any volunteer for this case? Any volunteer for this case? This is daily work, ultrasound. Any volunteer? Any volunteer? سامعيني انتو؟ الو
نعم أستاذ.
سامعيني؟
السلام عليكم.
عليكم السلام. Any volunteer for simple case? This is very simple.
This is ultrasound of the abdomen through the portal vein.
Okay.
Showing dilated portal vein.
Dilated water vein. ما حاطين احنا هنا يعني
The color Doppler.
with the color Doppler. Okay. ما حاطين measurement يعني. Okay. مش
I
مشكلة.
think it is decrease in the velocity if there is dilatation of the portal vein.
قديش الفيلوسيتي هون؟
The velocity 15.
Okay, it is 15. Normally how much? Normally it is around
Portal
15.
vein
It is
around 15.
around 15. It is normal velocity. And the wave is normal or abnormal?
What?
The wave of the portal vein spectrum, it is normal or abnormal?
It is monophasic.
It is monophasic, okay. It is monophasic, undulating.
Monophasic, showing respiratory phasicity.
Respiratory, okay. So this is normal or abnormal?
Normal.
This is normal
Normal.
wave.
And the flow of the blood, from where it is coming?
Hepatopetal.
Hepatopetal. Okay, very good. So this is normal. This is normal ultrasound of the portal vein. And this is some facts. The normal portal vein measurement, it is about less than 13 millimeter. And as you know, this is an echoic structure, runs in a transverse plane and converge on the porta hepatis, surrounded by sheath of echogenic fibrous tissue. And on the ultrasound spectrum wave, it is continuous wave pattern with monophasic, as we said, and it is hepatobetal flow toward the liver. Okay, so we can move to the second case. This is not. This is abnormal regarding to the first one. What we see here.
Thrombus inside the
Cavernous
portal vein.
transformation.
Look at carefully. It is cavernous transformation, or you see something else. This is the portal vein here, okay? It is looks like expanded, and there is some flow
Thrombus.
inside it, and some there is no flow. So what is this here in that area?
Thrombus.
Thrombus, it is okay. So this is portal vein, partial portal vein occlusion in this example. And you see, this is the echogenic area in that area, and the less echogenic area in that area, this is the flow as we see here. And the echogenic area, it is the thrombus, it is partially filled the portal vein. And this is thrombus in the portal vein, partial thrombus in the portal vein. And the flow of the blood, it is ash. It is normal flow.
Hepatobetal.
Hepatobetal. Okay, very good. Hepatobetal flow with partial thrombus. Okay. And we move to the third case. And what is the third case here?
Hepatofugal.
Okay, what you see? What you see?
فيستولا وكأنه فيستولا.
You see the portal vein here. This is the portal vein here, and what?
There is reverse flow of the portal vein.
Okay, reversible of the portal vein, and we call it hepatofugal. Okay, away from the portal vein, away from the liver. And this patient has cirrhosis, okay? This patient has cirrhosis, and we have reversal flow of the portal vein, hepatofugal, with under the baseline, as we see here. And this is patient with cirrhosis, okay? Any question on this? We move to the next case.
This is cavernous transformation.
This is cavernous transformation. Okay, what is the cause of the cavernous transformation?
Complete thrombosis of portal vein.
Complete thrombosis of portal vein. If you want to describe the finding, how you describe it?
The main portal vein is not well visualized. It's
the
replaced
main
by.
The vein is not well visualized. Okay.
It's replaced by this abnormal
serpiginous
color. Yes.
Okay, serpiginous tortuous collaterals in the porta hepatis. In the porta hepatis, and giving the appearance of the cavernous transformation. And this is a classic spot diagnosis. Okay. Okay, move to the next case. What is the next case? Simple
Azygous lobe. Fissure.
This is azygous fissure. Okay. Okay. Okay, in that area, how many layers in the azygous fissure?
4.
4
4.
layers. two كيف يعني
2
بيصيروا
parietal, 2 visceral.
2 parietal and 2 visceral. And the coma shape here, what is that?
Azygous lobe.
Azygous ايش؟
Lobe.
Azygous
Vein, sorry.
Azygous vein. Okay, azygous vein. Okay. Percentage of azygous fissure, how much? You know?
2%.
0.5.
0.5%. 0.5. What? And this is what we see on the CT scan. This is the fissure here, and this is the vein. Okay. And what is the most common accessory fissure of the lung?
Inferior.
Inferior accessory fissure. Very good. It is inferior accessory fissure. And what is the name of the fissures here in this one and this one? I will magnify, okay? The first one, the first line, and the second line. What is the name of the fissure here?
oblique and horizontal fissures.
Which one oblique, which one horizontal fissure?
The above one is the oblique. The second, the
above
one
one,
is the horizontal.
the above one is oblique or horizontal?
Oblique.
Oblique, are you sure?
Horizontal, separate the upper lobe from the middle lobe.
Okay, then the horizontal and the oblique fissure. Okay, and in between the middle lobe. Okay, very good. Okay, we move to the second case. Okay, the second case, we need the findings. We need
Pneumomediastinum.
try to describe all the things. Okay, and it is more. There is more than other than a pneumomediastinum. Okay.
Surgical emphysema.
What is the first? What is the procedure here?
Chest X-ray PA view
Just
in a
X-ray.
critically ill patient.
Okay, critically ill patient. Okay, very good. What you see?
There is a surgical emphysema.
Emphysema where?
Surgical emphysema in the neck, above shoulder, chest wall, lateral, right lateral chest wall. And there is a lucency around the mediastinum, the heart, and extending up. It's pneumomediastinum.
Mediastinum. Okay. And
opacity above left upper apex.
of above what?
Left apical opacity.
Left apical opacity. What does that mean?
Could be aortic injury.
No, the mediastinum width, it is okay. Okay. Mediastinum width, it is okay. Okay. Is there anything else?
Fracture ribs.
Fracture ribs, there is no fracture rib, apparent fracture ribs. What are the signs of pneumomediastinum in this patient here?
Continuous diaphragm.
Okay, continuous diaphragm. Okay, okay, very good. And what else? Is there any pneumothorax in this patient here?
I think there is a small right upper.
Okay, very good. There is a small right upper pneumothorax here. Okay, there is a small upper right pneumothorax here on this patient. Okay, very good. What is the name of the sign for cervical emphysema? If the air dissecting the pectoralis muscle, giving the appearance of what?
Kingo leaf sign.
Kingo leaf sign. Very good. Kingo leaf sign. Okay, very good. So this is patient with trauma with pneumomediastinum and cervical emphysema and pneumothorax. How we differentiate pneumomediastinum from pneumopericardium?
By changing position of the patient, lateral.
Okay, other than this, how we can changing patient is critical. It's critical is sometimes you cannot move the patient.
Extending lucency above the aortic knuckle.
Extends the lucency above the aortic knuckle means that it is a
pneumomediastinum, not pneumopericardium, because pneumopericardium it will be.
Okay.
Yes.
Pneumomediastinum. Is the pneumopericardium can give continuous diaphragm sign?
I don't know.
Okay.
Pneumoperitoneum can give continuous diaphragm sign.
Pneumoperitoneum can give the continuous diaphragm sign, and the pneumomediastinum can also give continuous diaphragm sign, and even if there is the pneumopericardium can give, but it will not extend laterally, okay, too much. It is only extend around the pericardial cavity, okay?
Okay.
To certain limit, okay? So this is trauma patient with, okay, this case, we need full description. We need first spot diagnosis, and next I need full description, the procedure, describe the finding, and the differential diagnosis and the diagnosis, okay? Most likely diagnosis. First, spot diagnosis. What is this?
Left upper lobe collapse.
Right.
Right upper lobe collapse.
Right upper lobe collapse. What is the name of the sign?
Golden S sign.
Golden S sign, okay. Right, okay. Now you can describe the findings in little bit detail, okay?
This is chest X-ray,
okay.
PA view. Opacity is seen in the right upper lung. And the right lung is small in size, elevated right hemidiaphragm with elevated right, and the right hilum is also elevated. There is endotracheal intubation. The most likely cause could be if it's adult, if he is adult, tumor tumor. In children, we should put foreign body inhalation or mucus plaque.
Okay, these are the differential diagnosis. What is your diagnosis?
Bronchogenic carcinoma.
Why? You see any mass lesion here?
The right hilum is there is an opacity on right hilum. I can see something here.
Okay. Okay, there is opacity here. Okay. What is the the concave bottom here? Here you see concave adjacent the lower margin of the inferior margin of the opacity. What is that?
This is caused by bulging of fissure.
This is
because there is
retraction, not bulging. Bulging is outward, but retraction.
sorry, yes, retraction, because there is loss, so there is retraction of this
Okay,
fissure,
retraction.
and the lower
The
part is
lower
caused by
one,
tumor.
the
It's caused by tumor.
by the tumor, and this is the tumor here. Okay.
Yes,
This is the tumor here, and because there is collapse of the right upper lobe, the hilum is elevated, and this is the mass. It is bulging, bulging here, and this is the minor fissure. It is here, little bit convex, and this is the this is the S shape here.
Tumor.
Okay.
Yeah.
This is the S shape. This is golden S shape. The other findings? Is there any other findings?
Endotracheal tube.
Endotracheal tube, okay. Endotracheal
And there is
tube,
fixation.
or this is endotracheal tube, or other than
Tracheostomy.
This is a tracheostomy, okay. This is
Yes,
a tracheostomy, okay. This is a tracheostomy.
There is nail
is okay.
on the right.
Position is okay first.
Do you want to do
Position is
5
okay.
cm above carina? It's normal.
Okay, it is position. It is relatively okay. في شيء other than this?
Nail fixation in the right humerus.
Okay.
Right humeral head.
Okay. في other things?
Left upper zone, small pulmonary nodule suggests secondary.
Okay, very good. Very good. This is another small nodule suggestive of overlying the rib, suggested of secondary. Okay, very good. Three other things in this patient.
Left clavicle.
Left clavicle, it is
old fracture.
It is all the fracture. Okay. So this is a classic case of golden sign with the bronchogenic carcinoma with nodule metastasis to the left upper zone. What is the stage here in this patient?
Stage 4?
Stage 4, yes. Any question for this? Okay, next case. Next case. Anyone? Any volunteer for this case? It is very simple. Any volunteer? يلا يا ايفون فتحت الميكروفون تاعك if you want to talk. Anyone? Any volunteer for this case? It is very, very simple.
IV contrast.
Intravenous biography
Okay.
of the bilateral kidney. يعني whole show there is a duplication of the right kidney and the ureter till the reaching the bladder.
Okay.
No obvious abnormality, any other abnormality, no following defect, no
Yes.
dilatation, apparent dilatation.
Okay, you said this is intravenous biography or intravenous urogram? Which is better?
Urogram.
Urogram. Okay. So this is intravenous urogram. Why urogram is better than biography?
The whole urinary system.
The whole
kidney.
urinary system is involved. Okay. What is you know what is Meyer-Weger law?
This a sign of the duplication of the kidney. يعني
What does that mean?
يعني upper يعني upper duplication يعني upper and lower.
Okay, there we have here duplication. If we want to apply the Myers-Weger law, this is the upper moiety, okay, and this is the upper moiety, and this is the lower moiety, okay.
Okay.
Where is in which one the upper or lower moiety has ectopic orifice?
The upper moiety.
The upper moiety has ectopic orifice, okay? And the upper moiety also, it is prone to obstruct. And it is medial and inferior to the lower moiety, okay?
Okay.
But what about the lower moiety?
Prone to reflex.
Orthotopic insertion إلها.
Orthotopic insertion. شو يعني؟
يعني in the right position.
In the right position, okay. And it is prone to
reflux.
Very good. So this is the Meyer-Weger law. Upper moiety, ectopic in position, inferior medial, and has prone to obstruct, and lower moiety, it has to reflux with normal ureteric orifice position, okay? Okay, this is what we said. Upper moiety, lower moiety, lower moiety is orthotopic in position. May reflux. Upper moiety may obstruct inferior medial and ectopic in location. Okay. Next case, what is this? What is the name of the procedure here?
DJ stents bilateral.
Okay, what is the name of the procedure?
3D CT rendering.
3D volume rendering technique and showing what? Double J stent bilaterally. Okay, very good. Which one anterior, which one posterior position? This is
the left one is anterior. The left one is anterior.
The left one is posterior. You see
posterior.
the spine here, okay?
Yes, yes.
Right.
And the right
one
one
is anterior, okay?
anterior.
What
Yeah.
is this here? Hmm? There is bony defect, okay?
Yeah.
Bone islets?
There is bony defect. We don't know. Probably previous surgery, this one, huh? Okay. Okay, this patient. What is the, who, any volunteer for this patient? Any volunteer for this patient? If you want to talk, Mariam Isa, if you want to talk, talk.
Two sections of coronal CT scan native study showing left ectopic malrotated kidney.
Left ectopic malrotated kidney, okay.
With the atherosclerotic changes of the lower aorta and both iliac arteries.
Okay. Any other things?
I don't know.
Okay, I will help you.
Jointless hypertrophy of the prostata.
Okay.
Hypertrophy of what?
Prostate.
Okay.
Prostate.
Okay, ماشي. Okay, في other things? What about the left kidney? What about the left kidney? There's hydronephrosis or not?
There is hydronephrosis.
There is hydronephrosis on the left kidney. What is the cause?
Yes. Yes.
What is the cause? What is the cause of hydronephrosis? What is this here? اللي عليه السهم. Hello, what is this?
Calcified ureter?
No. This is artery. This is artery, okay? Internal or external iliac?
Yeah, yeah.
Okay, because you see the calcification on the adventitia of the layer of the artery. And you see here above it, this is the dilated ureter, okay? You see the ureter here, okay? And the stone,
calculus.
and the stone, it is in middle of the, in the middle lumen of the left ureter. This is the, patient has stone in the left ureter causing hydronephrosis, okay? This is the patient causing hydronephrosis, okay? And this is the external iliac artery. And as you see here, this is the common iliac, external iliac, and the aorta has some atherosclerotic changes with it. And also the prostate relatively enlarged with some osteoarthritic changes of the both hips. Is there anything in the pancreatic head? You see here, this is oblique reconstruction, and this is the duodenum here. Here, this is the duodenum. I think the pancreatic head, طبعا we cannot judge 100%. This is the pancreatic head, relatively slightly enlarged, okay? And this is non-contrast study. We want to see the other reviews of this patient, okay? Any question of this?
Okay.
So this is left kidney with hydronephrotic changes with stone in the left ureter. Okay. Next case. Today are simple cases. Okay. What is the finding?
Axial section CT scan, native study, showing bilateral multiple areas of calcification occupying the medullary pyramids. Medullary nephrocalcinosis.
Medullary nephrocalcinosis. Okay. What are the causes? You remember any cause of the medullary nephrocalcinosis?
Hyperparathyroidism. Medullary sponge kidney.
Medullary sponge kidney. Okay.
Papillary necrosis.
ايش هو؟
Papillary necrosis.
Papillary necrosis. Okay.
Renal tubular acidosis.
Tubular acidosis.
Okay. بعد.
Hypervitaminosis of D.
Hypervitaminosis D. Okay. Sarcoidosis can be caused.
Hyperthyroidism.
Hyperparathyroidism. Sarcoidosis can be a cause.
Sarcoidosis.
Okay. These are some of the causes of the hypercalcemia. طبعا hypercalcemia, hypercalciuria also one of the causes, and can be associated with Cushing, multiple myeloma, bone metastasis, huh? Okay. We can move to the second case. Okay, any volunteer for the second case?
Axial CT scan with IV contrast.
CT scan.
With IV contrast.
With IV contrast.
Showing well-defined fat density mass on the right side, mainly originated from the right kidney, with some hyperdense strands.
With hyperdense age?
With hyperdense foci of tissue or strands from the lesion.
The mass, it is exophytic or non-exophytic?
I need more sections. The coronal
only
section.
with this one. It is exophytic.
Replacing.
Huh?
Replacing.
Exophytic.
Okay. It is exophytic. Okay. And it is most of in this kidney, it is occupied by the mass. The mass has fat density and has soft tissue density. And also the mass has some vessels in it, prominent vessels, as we see here, okay? This is vessel, this is vessel, okay? So yes. What is your diagnosis?
Angiomyolipoma.
Angiomyolipoma. Okay, very good. This is a classic example of angiomyolipoma. Okay. What is the relation between angiomyolipoma and tuberous sclerosis?
In tuberous sclerosis,
multiple bilateral seen in 80% of cases of tuberous sclerosis.
والله عيديها مرة ثانية لو سمحتي.
multiple bilateral angiomyolipoma seen in 80% of patients with tuberous sclerosis.
Okay. وإذا كان لحالها, how much the incidence of tuberous sclerosis?
20%.
20%. So 20 and 80%. Okay. How many types of angiomyolipoma you know?
I don't know.
Anyone?
Lipid rich, poor.
Huh?
Lipid rich, angiomyolipoma, and lipid poor.
Okay, lipid rich and lipid poor angiomyolipoma, and the mixed one. Okay.
Yes.
And this is the classic type, and it is account about 70%. Okay, lipid rich. Okay.
Okay.
Any question? Next case.
Axial CT scan with the IV contrast at the level of the pelvis, showing midline well-defined fluid density cystic lesion of thin wall, the midline posterior to the bladder, anterior to the rectum.
Okay, what is your differential?
Duplication cyst.
One of the differential, yes. Other differential? What age?
Tail gut cyst.
Tail gut cyst. It should be posterior, huh? Posterior
yes, posterior.
Yeah, posterior to the rectum. Okay. Other differential. This is female patient, by the way.
Dilated cervix.
Ovarian cyst.
Dilated cervix.
Hematocolbus.
Ovarian cyst.
Ovarian cyst. The differential. Okay. Other differential.
Dermoid, epidermoid, lymphangioma.
Meningocele. Any other?
Meningocele. Meningocele.
Meningocele should be
posterior.
Posterior to the rectum.
Okay. Okay. So what is your question you want to ask to reach the diagnosis? Only one question allowed.
About the mensa of the patient.
Okay. And what is the next step? You want any image you want to confirm your diagnosis?
Ultrasound pelvis.
Sagittal of the CT.
Ultrasound.
Sagittal, okay.
Of the CT.
CT or okay, or ultrasound or MRI. This is the sagittal CT scan, and you
Hematocolbus.
Hematocolbus due to imperforate hymen. Okay.
Yeah.
Okay. You should mention imperforate hymen causing hematocolbus. Okay. Okay. Next case. Okay, next case.
Okay, sir, can I talk?
You can talk.
These are selected image CT scan at the level of the kidneys without contrast administration. There is evidence of well-defined left rectal sheath lesion showing hyperdensity associated with perilesional fat surrounding soft tissue thickening on the left side. Okay, in the setting of the trauma, I will put rectal sheath hematoma.
طب إذا ما فيش هيماتوما إذا ما فيش تروما.
And maybe rectal sheath hematoma in other condition, non-traumatic condition.
Okay, very good. Patient is on coagulation. Okay. So this is a hematoma. في fluid level here, fluid level in this patient.
Yes.
Yes, fluid level.
Okay, you have a fluid level here in that area. Okay. So this is the rectus sheath hematoma in this patient. What other differential diagnosis, if you want to put, if the patient has no trauma, no coagulation, what other differential diagnosis?
Desmoid tumor.
Desmoid tumor.
Endometriosis.
If it is
metastasis.
Metastasis from where?
These are maybe ovarian pelvic origin metastasis or skin يعني deposition يعني metastasis.
From where? More common from where?
Myeloma.
Melanoma.
Yeah, I think the kidney, you will give very metastasis to the muscles, okay? So this is patient with anticoagulant and with hematoma of the left rectus muscle. Any question?
Yes, sir.
This case? Any question? This case?
Axial CT scan with IV and oral contrast.
Okay.
Showing fat density, rounded lesion with central hyperdensity and rim of fat surrounding in relation to the anterior aspect of the cecum.
Okay.
Otherwise, the film appears normal. The picture suggesting epiploic appendicitis.
This is consistent with epiploic appendicitis. What are the signs here?
Ring?
Hyper, yes.
Hypertension of
ring
central
sign. This is one.
hyperdensity, fat density.
This is hyper attenuated ring sign. This is one of the signs. Okay. The other sign.
Central dense.
Central, yes.
Dense visible inside it. Dot.
Dot or line sign.
Dot
or line. It depend on the section. Okay. Dot or line sign. What does that represent?
Thrombosis vein.
Thrombosed vein. Thrombosed central vein.
Thrombosis
central vein.
So this is the appendage here. Appendices. Okay. And this is the artery here, and this is the vein. Once it is torched, once there is torsion, they occlude the artery and the vein here become thrombosed. And if you cut it here like this, it will be a dot. Okay. If you cut it in long axis, it will appear line sign, line sign. Okay. Either line or dot sign, and you see also hyper attenuated ring sign surrounding by fatty tissue. Okay. So this is a classic case of acute appendicitis, and here this is on the right side. It's sometimes clinically mistaken by appendicitis. And here this is in a close relation or in the relation of the ascending colon. Okay, this is the in the region of the ascending colon. How we differentiate acute appendicitis from omental from omental infarction? How we can,
in addition to the
size
site
of the
or
lesion,
location.
number one.
Okay, the size. Okay, what is the size?
The size of the lesion or absence of hyperdense ring.
Okay, the size. How much the size?
Less than 3 centimeter goes with epiloic appendicitis. More than goes with omental infarct.
Yeah, okay. Some books it is written 5 centimeter. Okay. Between 3 and 5, it is less than 3 and 5. It is more with appendicitis. More than 3.5 and 5. It is more with omental infarction. Okay. Treatment is
Conservative.
Conservative with what? With anti-inflammatory drugs. Okay, sometimes we give antibiotic. Okay, so this is classic case of the acute appendicitis. Okay, okay, we can move to the next case. Spot diagnosis here.
Teratoma.
Dermoid cyst.
Dermoid cyst, teratoma. Okay, very good. What is the component of tissue here?
Fat density tissue.
Fat density
soft tissue and
calcification and
soft tissue.
And calcification.
And calcification. Okay, very good. Next case. This case.
Limbus, vertebral limbus.
Limbus vertebra. Why limbus? Not it.
Yeah.
Okay. What is the differential diagnosis?
Avulsion fracture.
Avulsion
Teardrop.
fracture. Here
Limbus, because it is corticated, and
it is corticated
because of the location at the superior part of the vertebral end plate, anterior superior.
Anterior superior and well corticated, and
corticated.
It is, okay. It is surrounded by what? End plates. مظبوط ولا لا? Okay, here.
Exactly, yes.
Okay, here. So this is this is limbus vertebra. Can be smaller node?
No, in the center. Smaller nodules in the center.
Can be also on the periphery. Okay, can be on the periphery.
Yeah.
Okay, can be on the periphery. Yani here it is could be here, but it is more with limbus vertebra. Okay. And you said can be a margin fracture, yes, but it is here well corticated. It is less likely to be a margin fracture. What about the infection? Here, 2 patients, by the way, not 1 patient. Okay.
Yes.
Yeah, and other differential. It is infection, but with the infection we see some bone
The disc is
destruction.
normal, maintained. The disc is maintained.
Yeah, maintain the disc and also the soft tissue around the part. Okay, around the anterior infected part. Okay, we move to the next case. What is that next case? What you see?
A frontal chest X-ray of skeletally immature.
This is a chest X-ray. Or dorsal spine.
This is a frontal view of dorsal spine X-ray.
Okay, this is dorsal spine X-ray. Okay, what do you see?
Abnormal vertebra.
Butterfly vertebra.
Yes.
Butterfly vertebra.
Butterfly vertebra. Which level?
C7.
Thoracic.
Sorry, T7.
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 T7. Okay, في شيء تاني؟
Cardiomegaly.
This is not for chest. This is dorsal spine. Okay, forget about the heart.
Spina bifida.
Spina bifida. Okay. Okay, and this vertebra. Okay.
T3. T3.
Okay. T3 or T4?
6, 7.
T4. This is T4.
T4. Okay, so you have spina bifida here and butterfly vertebra. What is the cause of butterfly vertebra?
Failure of the fusion of two halves of the vertebra.
إذا failure of the fusion of two halves, lateral two halves of the vertebra with persistent what?
There's notochordal tissue.
Notochordal tissue in between. Okay, so failure of the fusion, the lateral half here and the lateral half, and persistent of notochordal tissue in between. And here, this is the spina bifida. حدا بيعرف شو اسمها بالعربي؟ Anyone knows this name in Arabic? ما في خريجين الشام هون؟ السنسنة المشقوقة. ها؟
بقيها على الانجليزي استاذ افضل.
السلسلة المشقوقة. Okay. Okay. This is two findings here with spina bifida and butterfly vertebra. Okay. We can move maybe to the نشوف إذا في last case ولا لا. Okay. Next case. Next case, this case, spot diagnosis.
Spondylitis.
Spot diagnosis.
Slipping.
Oblique.
This is first.
Oblique.
This is oblique. This is oblique
view
view
of the
of
lumbar
the
spine.
lumbar spine. Okay, what you see in the oblique view on the lumbar spine?
Pars defects at the level of L5.
Okay, very good. There is a defect in the pars interarticularis.
Decapitated Scotty dog.
Okay, a Scotty dog. This is a defect here. This is a Scotty dog defect. Okay, and this is indicating what?
Spondylolysis.
Spondylolysis, very good. This is spondylolysis. Okay, and this is the Scotty dog here. Okay, and this is the defect here, as we see here. This is the defect in the neck. Okay, the Scotty dog. And here, this is the anatomy. This is the superior articular facet. This is the pedicle here. And this is the transverse process. And this is the defect in that area. Okay, pars interarticularis. And this is the inferior articular facet. So here, so this is superior, inferior articular facet, pedicle, transverse process here. This is the transverse process, pedicle here, and the defect in the pars interarticularis. Okay, so this is defect in the pars articularis indicating spondylolysis. Okay. Okay, and this is the same what we discussed. This is the Scotty dog sign. Okay. Okay, we can stop here and إن شاء الله ما بعرف إمتى العيد هو؟
العيد تقريبا 1/8 أستاذ، بداية الثامن.
بداية الثامن. حددوا
نعم.
حددوا ذي الحجة؟ حددوه ولا ما حددوا؟
هو تقريبا 1/8 تقريبا.
يعني حددوه يعني صار 1 ذي الحجة ولا ما صارش؟
لا هم ما
الأربعاء
ثبتوا لي لا لحد اليوم أستاذ بعد.
أوكي. ممكن إحنا نشوف ناخذ لنا one session next week إذا نشوف حسب التحديد. ها إن شاء الله.
إن شاء الله.
إن شاء الله.
شكرا أستاذ.
يا أما ناخذ one session next week أو بنشوفكم بعد العيد إن شاء الله.
شكرا أستاذ.
شكرا. بارك الله فيك.
بارك الله فيك
إن شاء الله.
إن شاء الله.
شكرا جزيلا.
كل عام وأنتم بخير إن شاء الله.
وأنت بخير أستاذ.
وأنت بخير أستاذ.
يلا في أمان الله، مع السلامة، نشوفكم